I have the pleasure of introducing Dr. Kaitlin Sundling, who is a physician scientist and assistant professor of pathology in Wisconsin, who brings her expertise in science and medicine to her public health advocacy work. Dr. Sundling is a staunch advocate for healthcare masking and improved COVID protections in her community in Wisconsin. She is a member of the Wisconsin Community Health Action and has formed the COVID Precaution community on Discord. Her advocacy has been featured in media outlets, including Wisconsin Public Radio, NBC News, and Forbes. Dr. Sundling will present on the impacts of COVID in pathology and cancer care. Dr. Sundling, you have the floor.
Thank you so much. So I wanted to talk with you today about a topic near and dear to my heart. And of course, this is how COVID impacts a lot of aspects of medical practice and pathology, as well as cancer care, both for our patients and how we actually take care of our patients in pathology. As Dr. Kavanaugh mentioned, I am a pathologist and physician scientist. So I am a doctor who uses a microscope more so than a stethoscope. And I'm mostly behind the scenes in the lab. I know we have a broad group of backgrounds, so I'm going to keep this talk relatively broad. And I really invite any questions at the end. I just want to recognize that there may be people in this room that have greater expertise in some of these areas than I do, and I really welcome that discussion. My specific subspecialty in pathology is cytopathology, and this is where we work with really small samples, and we have mostly a focus on cancer and pre-cancer diagnosis. So I'll be talking a little bit about that and a little bit about a lot of broader issues where a lot of my interests intersect. First, I wanted to talk about the Pap test. And this is something we all know about. We've all heard about it. The Pap test is our main cervical cancer screening test that's been in use for decades. But some folks might not be aware of really how the Pap test has been a public health success story. It hasn't always been easy. There's this great documentary from the American Experience on PBS that I would highly recommend. This highlighted some of the history of the Pap test that actually I didn't even know, going back to Dr. George Papanicolaou, who really pioneered the method, and really broad history, including some of the early integration into even things like eugenics. But going into how the Pap test has really helped public health, cervical cancer used to be the leading cause of cancer death in women and people with a cervix. And in this graph, you can see we've started tracking specifically cervical cancer since 1975, and you can see a precipitous drop-off with wider and wider adoption of the Pap test. And on the next plot, this actually combines deaths due to all uterine cancers, and that's the purple line. And you can see going back to the 1940s, the purple line, the cervical uterine cancers were the leading cause of cancer death in women and people with a cervix. And so this has really drastically declined with adoption of the Pap test. And this is because the Pap test can actually identify cervical cancers early. It can identify precancerous lesions, so what we call dysplasia or precancers in the cervix, before they even become an invasive cancer. And those problems can be treated so that patients can live longer. And now actually we see these precancers be completely cured with appropriate follow-up and treatment. So this is a great success story, and we see that this has had a huge impact on our patients. Going into the biology a little bit, we actually do have a viral cause of cervical cancer. Human papillomavirus is the main cause of the vast majority of cervical cancers. There are some types that are not driven by HPV, but the main one that we're looking for and trying to prevent is HPV driven. Cancer screening, as you might expect, has been impacted by the pandemic. And when I think about this, I kind of compare to other cancer screenings. So we might compare cervical cancer screening to breast cancer or colon cancer screening. All of these screening methods did see a drop, and some have seen subsequent sort of rebound in screening. So some patients have caught up to the screenings that were missed in the early days of the pandemic when a lot of healthcare was quite shut down and sort of prioritizing more emergent matters, prioritizing patients who needed acute care. Cervical cancer screening volumes, though, have not returned to baseline and have suffered a significant drop. So there are some confounding factors with this, but I just put this in the context of we have seen some patients who have missed screenings and not everybody is caught up. One thing that's interesting about all of this is that cervical precancer rates overall have held steady. So we do actually see a relatively sort of maintained baseline for our low-grade precancers as well as our high-grade precancers down here. So we are still seeing these diagnoses, but there is a concern that some missed cancer cases, some missed precancers may still not have been caught with catch-up screening. One thing that I mentioned is a confounding factor is that we have actually had a change in our screening guidelines. So if you compare the middle column, the 2012 guidelines from the American Cancer Society, to the updated 2020 American Cancer Society guidelines, which were implemented right about at the beginning of the pandemic, we've actually decreased screening frequency quite drastically. So this is a product of the Pap test being so successful and the rates of invasive cancers becoming really quite low. Particularly in younger age groups, we're seeing that the benefits of screening a younger age group are not as high. So the American Cancer Society screening guidelines have decided to defer screening. The first screening would occur at age 25 under these guidelines. In the US, we have an alternate option that is currently under review but has not been updated yet. So some patients are still being screened starting at age 21. So we are seeing a later onset of the start of screening, and this may have some impact as well. The other thing that we're seeing is a shift from the traditional microscopic methods that we refer to here as the Pap test, but I'll also refer to as cytology, that gives us those pretty cells we can look at under the microscope, to testing for the actual causative agent of most cervical cancers, which is HPV, with an HPV test. HPV testing is highly sensitive, but it doesn't give much more information beyond HPV is detected and which genotype is present. So in the past, we've typically done a combined approach where we may, in some younger patients, do cytology alone, but then in older patients incorporate the HPV testing. Now HPV testing upfront is being preferred. So this was just to give us a little bit of a window into a virus that is very well known to us. We have multiple ways to prevent the harms of this virus, and we have multiple ways to actually detect the virus. COVID itself does impact cancer screening. I really encourage everyone to catch up on screening. And HPV primary screening, when we do just the HPV test, this is actually some option that we can add on to what we're already doing. There is a possibility of doing an HPV test on a self-collected sample so that the patient might not even have to go for a clinic visit to get a vaginal sample that could be used for HPV testing. This is already done in some labs across the country. It's something that we're working on in our own lab. Unfortunately, it does require validation of the testing platform. The manufacturers have not taken on this FDA approval for self-collected samples, so we're required to validate those within each lab where our self-collected samples are used, despite having a lot of publications that self-collection can work really well. So this can actually expand our screening options for patients who may have difficulty getting in for a doctor's appointment or for situations where healthcare overload might be a problem and there might be delays in screening. It's also really important for patients to catch up on HPV vaccination if they may have missed those vaccinations, either due to the pandemic or due to other impacts. I wanted to draw a few more parallels between COVID and HPV. So COVID hasn't just impacted cervical cancer screening, but we see a lot of parallels in anti-vax, the sort of feelings about both COVID vaccines and HPV vaccines. So the figure here is about HPV vaccination, and just to demonstrate that we see there is increasing HPV vaccination with age. It is really important for preteens and teenagers to get HPV vaccination before they become sexually active, because HPV is sexually transmitted. It's really important to get vaccinated at an early age. However, we're seeing that actually a lot of kids are getting vaccinated a bit later into their teen years. So this is sort of a little bit of a gap where we have some opportunity to do better. But I'll just point out a few issues that might ring a bell when you think about the anti-vax sentiments that folks might have about the HPV vaccine, and see how many of them might seem similar to things you've heard about COVID vaccination. People having concerns about the safety, people thinking that the vaccine might not really be necessary. Cervical cancer is a cancer that has fallen a little bit out of the public memory. Watching this documentary on PBS was a really good reminder that there used to be entire wards of hospitals that were dedicated to cervical cancer patients, and we don't often see that. So that can kind of lead to this feeling that HPV vaccination isn't necessarily relevant in our day-to-day lives. Sometimes the issues are lack of knowledge about the vaccine, and then sometimes there is a lack of physician recommendation. It has been sometimes challenging. I think our pediatricians and family doctors are under a lot of pressure. They have to bring up so many different things in each visit, and prioritizing vaccinations hasn't always happened. So ways that we can make that easier, I think, would definitely help. And then this is more particular to HPV vaccination, but thinking about, oh, this doesn't apply to my child because my child's not going to be sexually active. So sort of misunderstanding that this is actually a vaccine that can prevent a cancer, and that cancer is not going to be a problem for many, many years. So the time for vaccination is now, but the benefits are really lifelong. So I think many of these do also ring true for COVID vaccination. And I think that there are ways to think about vaccination approaches that could benefit multiple vaccine types, both COVID and HPV vaccination. I wanted to give just a little refresher. We have a number of different viruses that are known to drive cancers. One of the questions that I had talked with Dr. Kavanaugh about before this talk was about talking about, are there any direct connections between COVID and cancers? I really thinking about a spectrum of different viruses. HPV, of course, was first and foremost in my mind, but then hepatitis B virus is another virus that we know predisposes patients to liver cancer. And going down the list, I actually had to refresh my memory. I have seen Merkel cell carcinomas. This is a rare type of skin cancer, but I had forgotten the connection also with Merkel cell polyomavirus, a bit more of a rare one. But these other viruses are not all that rare, particularly Epstein-Barr virus. And Epstein-Barr virus is a virus that many of us are exposed to, and in some patients can be associated with a variety of different malignancies. So cancers that are associated with viruses are not really rare, but it can take some time to make those connections. So I wanted to first start in COVID talking about the histopathology that we know COVID is associated with. What kinds of injuries can COVID cause? And of course, when we look at articles about COVID infections, the focus is often on lung damage, but we know that COVID is a systemic infection. So this is just an example of some of the spectrum of lung damage that we can see. So this is normal lung, a nice comparison where you see really thin alveolar septae. And so these are just the really thin, light air spaces. You should be seeing a lot of white space in here because that's where the air would normally be. And here in this lung section, you can see these spaces. You can kind of start to still make them out, but they are filled up with stuff. And that stuff is inflammatory cells as well as fibrin. So you're getting some beginning of the formation of hyaline membranes, this pink material, which makes it really hard to get good gas exchange through the alveolar walls. And that can make it really difficult to breathe. So this is getting toward a more severe case of pneumonia. Here you can see a blood vessel that has inflammatory cells throughout the walls, so some damage to a blood vessel here, which is a common theme. And then this is a really advanced case of lung damage due to COVID, where you don't just have filling up of the air spaces, but you actually have filling up and sort of a fruitless attempt to repair the damage that's been done. You actually get cells coming in there trying to repair and forming these little plugs where the airspace should be. So you see very little white space left within this area of lung, which indicates it's not going to be very functional. But COVID does have systemic manifestations. There can be a kidney damage, particularly a couple of different ways that there can be damage to the glomeruli, which are a very important part of kidney function. We can have clot formation, thrombus formation in small bowel, in the spleen. This is a higher power view of the spleen where you can see some inflammatory cells as well in the area of this clot or thrombus formation. And then you can have splenic thrombus and even infarct, meaning that there's a loss of blood supply and oxygenation to part of the spleen. So that gets us back to this question: does COVID infection itself impact cancer risk? And I was not able to answer this question for this talk, but what I could come up with is that people are looking into this, but the long-term impact of COVID infections on cancer risk is not yet known. This is something that's likely to take years to manifest and perhaps even longer to understand if we aren't careful in looking for it. So some strategies, sort of just off the top of my head, could include doing prospective studies that would include the number and frequency of COVID infections when we're looking at different cancer outcomes. In studies of patients with long COVID, we would want to include cancer outcomes in those studies. And then there is already quite a bit of work being done on cancer biology investigating shared pathways. And I think this is just important to keep in mind that we don't have the answers yet, but this is something that we're still learning a lot about and something that could definitely have far-reaching consequences. So another reason to take precautions, another reason to protect ourselves in this ongoing situation of COVID spread, at least as I'm seeing in my daily life. So one thing I wanted to point out, that cancer is not just one disease. I think, as many of us know, this is a diagram of the hallmarks of cancer. This is just one framework for understanding the molecular biology of cancer and how cancer can be targeted with therapies as well. There are many different ways that cancer evades our responses that actually keep cancer growth in check. And then long COVID is perhaps not just one disease as well. And this is just one diagram that was highlighting different hypotheses for long COVID mechanisms. And I would just say we don't have to choose just one in either of these situations. A lot of diseases span multiple biological mechanisms in their progression. So what can people affected by cancer do about COVID? And I think the key, when I'm thinking about public health advocacy and what can I do to help in my community, I want to help inform folks that they can take multi-layered precautions against COVID. That this is not an infection that we have to be okay with, but this is something that we can reduce our risk. We can only go so far individually, but when we take multi-layered precautions, we can reduce the risk quite drastically. So masking, particularly with high filtration respirators, improving air quality through ventilation and filtration, using distancing, so both physical distancing, like reducing the density of people within spaces, as well as using virtual options. That's an important piece that I personally utilize quite a bit. And then testing so that people who actively have COVID infections are able to stay home, isolate, rest, and not spread their infections to others, as well as vaccination. So a lot of people in my community will ask about one-way masking versus universal masking. And I just always like to remind everyone that universal masking does actually multiply the protection. So this is an estimate from a CDC study where they looked at use of N95 respirators by the general public who weren't actually formally trained on using N95 respirators. So we can actually do better than this on one-way masking. But if we look at kind of like typical use, we know that respirators aren't perfect. But if we can use universal masking, we can actually actually multiply that protection by providing source control as well as protection for the wearer. And one of the key things that I've been champion of and trying to improve in my local area is masking in healthcare. Throughout the winter, we actually had universal masking, at least in sort of the majority of interactions in some of our local hospitals, but that was recently rolled back. And like many other healthcare systems across the country, they may only require masking in the sort of defined high-risk locations, such as in cancer clinics, transplant clinics, and other places where they've identified particularly vulnerable patients are for sure attending those clinics. But that means that in lobbies, waiting areas, and elevators, we often don't have required masking. And then it's often neglected that patients with cancer, as well as other immunocompromising conditions, do seek care throughout healthcare systems and not just in those dedicated high-risk clinics. One thing that I've addressed talking with people in the community is understanding that people who are immunocompromised may qualify for additional COVID boosters. And it's important for patients to know, too, that they can self-attest to their immunocompromised status. They don't need to present specific documentation, and this is outlined in the CDC's recommendations. And then we now have a monoclonal antibody that is available for prophylaxis for patients who may qualify. I haven't seen yet how widely this will be used, but this was exciting to see because this is definitely going to be important for patients who don't have as great of a vaccine response and may not be as protected. Cancer itself and the history of cancer does increase the risk of COVID, as you may expect. Unfortunately, COVID mortality is higher in patients who have had cancer, both whether they've had recent cancer treatment or whether they've just had a history of cancer and have not recently had cancer treatment. You can see that when there has not been recent cancer treatment, the mortality rate is a bit lower. This effect actually went away when the data were adjusted for patients' comorbidities. But the truth is that cancer treatment often creates those comorbidities. So patients with a history of cancer do need to know that they may be at a higher risk of severe COVID infections and a higher risk of death due to COVID. So the stakes are higher, and I would really like to see broader efforts to help support and educate and provide resources for patients who have a history of cancer so that they can protect themselves and that healthcare providers can be educated on the risks within the healthcare system of spreading COVID to these vulnerable patients. Just thinking about protections sort of in our daily lives and in our communities, I think a lot of you are aware of the CDC's recent rollback of isolation guidelines. This is one article that I was interviewed for where we talked about the impact that rolling back and reducing isolation has on sort of risks in our daily lives, as well as people's understanding of their need to rest and recover when they have COVID. This could definitely have an impact on cancer patients and immunocompromised patients in general as they go about their daily activities. It makes everything a bit riskier when you understand that people who may be ill and may test positive for COVID may not be even recommended to isolate. So I would really like to see more extended isolation guidelines that actually encompass what we know about the transmissibility of COVID during the course of an infection. Unfortunately, there are other parallels between COVID and cancer, and this has to do with misinformation. So this is another hot topic in the online communities, that there are really what I would call snake oil salesmen who are playing upon people's fears. We've seen this play out in patients who have cancer or patients who are personally impacted by cancers, people who may have a fear of cancer. And we see this now with COVID. There are a number of COVID precautions that are being sort of misconstrued, things that are not proven to work, but are being kind of sold as a precaution or a layer of protection. I've listed just a few of them here, but there are really, I would say, new ones that I hear about every week or so. And people are getting taken in by these unproven approaches, and they may not understand the health risks that they pose. Using an unproven approach also may lead to a false sense of security. And as in many patients who have been taken in by unproven approaches, this can cause financial harm, as many of these can be really expensive. So this gets to the last part where I'll talk a little bit about COVID impacts in daily pathology practice. So we've had pandemic impacts, including earlier retirements, on top of existing workforce challenges in pathology. We've seen increased retirements across the board, not just in pathologists, but also other laboratory professionals. We've had a reduction in the stream of incoming graduates to sort of fill those roles and keep a steady workforce, and variable adoption of options that might kind of extend what we can do, including, I'm going to give one example of digital pathology, as well as options for remote work that are possible. So this also impacts pathology training, and I've had some experience in making our pathology resident rotation more flexible and incorporating a multi-layered approach so that we can continue the work that we're doing. We can continue training residents, but we can do so safely so that we can really keep going and not have a risk of COVID transmission in our daily work. In 2020 to 2021, our lab offered a fully virtual rotation option for pathology residents. These are physicians who have decided to subspecialize in pathology, and they go through 4 years of training. We get them for only 1 month, but we were able to make that month fully virtual. We got to do their introduction to cytology fully virtually. That worked out pretty well, and the great thing is that even when we were able to kind of move back to on-site rotation, we were able to leverage the flexibility from that virtual rotation and make it really extremely flexible so that our pathology residents can complete the learning that they need to do, even when they face a variety of different challenges. So we had residents who were dealing with issues in their family life, residents who had illnesses, etc. And there was really no question of whether residents would be able to occasionally work from home and do other things that they needed to do in order to take care of their lives and still complete the pathology learning that they needed to do on our rotation. So there's a lot more that we can do, but these approaches aren't necessarily used across the board. We also need more inclusive practices throughout science and medicine. I'm really seeing that although a lot of scientific conferences went virtual in the early days of the pandemic, a lot of those virtual options are now being rolled back and going to like a fully in-person scientific conference. I would really love to see a more proactive approach across different disciplines to have multi-layered COVID and other infectious disease protection policies, as well as virtual options. I think it's very clear, including in forums like this, that we can do scientific collaboration virtually. It can be done very effectively. And this actually opens up the work that we're doing to a much broader range of people. I'll highlight this article, which gives 10 simple rules for an inclusive conference. I think the sort of diversity, equity, and inclusion angle has been highlighted in a lot of different scientific disciplines as an area that we need to improve. And somehow including disabled people as well as immunocompromised people and people who may have cancer or have a history of cancer themselves into our scientific communities is really important. And we can do that better if we have strong COVID protections. I already highlighted some of our staffing shortages across the laboratory and across healthcare in general. We also have some other challenges, including increased demands on pathologists' time, increasing expectations for biomarker data. We are learning more and more all the time about new markers that can actually tell us more about how a patient might respond to a certain therapy. And we want to do that testing on our patient samples, but we are also being given smaller and smaller sample sizes. And that gets into my chosen area of cytology. Sometimes actually what we get is just a tiny number of diagnostic cells. The other challenges are, can we be reproducible with our diagnoses, and how can we better integrate the diagnoses that we're making, the things that we're seeing under the microscope, with all of the other information that that patient is going to get, molecular testing results and other biomarker results that are going to be very important for the patient's care going forward. A solution might be here in machine learning and artificial intelligence. The traditional approaches that we've used in the past required feature extraction, which could be quite time-consuming and difficult. But the newer deep learning algorithms can actually classify images, including images of cells. I've got a benign cell. This is actually a cell from the urine. This is a bladder cell. And on the right, we have a bladder cancer cell. So you can see the nucleus is very dark. The contents of the nucleus are very irregular, and the nucleus takes up a huge amount of the entire cell area. So the machine learning algorithms can actually learn the differences between these images without doing pre-extraction of the features. So there's a lot more that we can do with this, and things that can actually help us do our jobs better and can help us maybe make our work go a little bit farther in the lab. And this is just an example of a machine learning approach that can be used for pathology for identifying cells of interest. You can think of this as our cancer cells, or even not just identifying what's a cancer cell and what isn't, but specifically subclassifying different types of cancers and giving us more information from a small sample. So we can do more with digital images than we could with traditional glass slide microscopy, but we aren't quite there yet. It's been very uneven adoption of these approaches. So I wanted to close with what I first thought of was a new approach to medicine, but thinking a little bit more about it, this is actually a very old approach to medicine. Rudolf Virchow, many of you may be familiar with the name. This is one of our forebears of modern pathology. He had several quotes, but I picked out these two to just highlight that we don't practice medicine in isolation. We are part of our communities, and we have to understand what's going on around us to make the best impact. So I really like this idea that medicine is a social science, that we really are dealing with the science of human beings. So we see ourselves as scientists, but a lot of the change that needs to happen to improve people's health and people's lives needs to happen outside of the healthcare system, outside of the lab, to actually protect people from infections in our daily lives and keep us all healthier and safer. I have a few recommended resources, and I have some selected references at the end. References were also on the slides, and I will open up to any questions. Thank you.